Welcome to today's webinar. The topic is the 15 till 50 Mass Casualty Incident Response Program presented by our guest, Chris Riccardi. Chris has many years of experience in the healthcare preparedness discipline, and we're excited to share his knowledge and experience with you. So without further ado, I'd like to turn it over to our guest, Chris Riccardi.
Thank you, Tom. Thank you, Cassandra, as well. Appreciate the opportunity and privilege of being able to share this information with you today. We have done quite extensive work on bringing this program together. I come from the healthcare realm. I worked as an emergency preparedness program manager for Providence Little Company of Mary Medical Center in Torrance and San Pedro for about the last 15 years or so. Where we've had the opportunity to create this program, and I had the honor of working with an unaffiliated hospital in putting this together so that we could share this with every and anyone, and I hope you'll find this to be helpful, or at least something that you will be able to utilize in your facility. Our objectives for today is to describe the methodology of the 15 till 50 Mass Casualty Incident Response Program. Just for your edification, the 15 till 50 is short for 15 minutes till 50 patients. And the process is to be able to rapidly deploy equipment, and we'll get into that in a few more minutes, and supplies with what you have on hand. I'll describe how to implement this in your facility, and this can be done in any healthcare facility. We've really gotten a lot of traction in the clinic setting, in the FQHCs, that they've been able to implement this process to, again, meet some of their CMS compliance as well as their community capabilities. And then I'll go through the toolkit resources, the 15 till 50 toolkit. We'll cover that towards the end of the presentation. So who are we looking to target with something like this? Well, obviously the healthcare emergency managers. I think, I came from a facility where I was a department of one. And hopefully by bringing this product together and in the way that it is, that you'll find that this can be implemented with relative ease within your environment. This is great for EMS personnel out in the field. Definitely helps to have an understanding of how hospitals will receive victims. The emergency department staff and physicians. This has been a very emergency department centric plan for hospitals, so that who would pretty much be the initial receivers for this event. So to set them up for success, how to have a good plan in place, hospital leadership for their understanding of this process, all hospital personnel and clinical staff. And you'll find within the hospital personnel that as part of the resources, there will be there's basically job action sheets, or at least a role and responsibility for every department in your facility. And again, that doesn't matter if you're in a clinic setting, long-term care, and or in a hospital. So we'll go over the overview of this process, the initiation activities, which is a key component, the setup procedures, roles and responsibilities. I'll get into the toolkit, and we will also field some questions from you. We'll take a little break in the middle of the presentation to open that up to questions as well. So please write them down or throw them on into the chat box, and we'll get to your questions. So might as well dive right on into this. So again, I had mentioned what 15 till 50 is, but this is really designed to enable hospital staff to receive a surge of 50 or more patients within 15 minutes of notification. That comes through whether you're getting this from your EMS providers, or we use a ReadyNet system here in Los Angeles County. And it's a very effective tool for disseminating information. So just however you would be notified, whether it be on the news or a text, this is a plan that can be rapidly deploying staff and supplies and equipment within that 15-minute time frame by having designated roles and responsibilities and a process. And that process is initiated using your existing supplies, equipment, and staff on hand. And that was a key component to this, was to, with the hospitals working at full capacity on a daily basis, how do we shift and accommodate to receive a mass number of victims at any given time? And this has been the plan that we have been using, and Over the last 10 years, it's been tested, modified. So what you're seeing today is not what it looked like when we first got started, but this took quite a few years of drills and practice and identifying gaps to and improvement processes to bring this to you, what you have before you today. One of the things when we first got started with this process was the lack of knowledge of a facility disaster plan. Whether or not they knew that they had a plan, I would ask folks if they know where their disaster plan is, and they kind of looked at you with a puzzlement. So again, not knowing your disaster plan, they didn't know what their roles were until they would be directed to do something. Definitely poor communications, and still to this day, no matter how many drills we do, the communications between treatment areas and when we move people into using handheld radios definitely becomes a bit of an issue. We've been making great strides in improving that. Unclear patient pathways. How do you provide throughput from a treatment area up into your hospital, whether it be to the operating suites and or into the rest of the facility? Lack of relevant supplies, and it was pretty amazing to see what the process we had in place before we actually moved into this one, and it was very helpful. And then again, even though the plan may say one thing, the response we would get is that's what it says, but that's not really what we do. So we needed to put together a process that it is what we do, and then to put that into make the plan around it to make it a functional process. So the solution that we came up with was this 15 till 50 process, and that is the rapid deployment of equipment, designated responses from everybody in the hospital. And I mean, once we call a code triage within the facility, everybody assumes the role that they are designated to do. And we'll get into a few more of the roles and responsibilities and how that looks. This has been vetted through over 30 exercises and events just at my facilities. This has now been adopted, although it says here for 20. I just recently found out that there are over 36 hospitals here in Southern California that have now adopted this plan and are using it for their mass casualty response. And this is a very, again, easy to implement. It's a plug-and-play model. You'll be provided with all of the tools and resources that you would need to do so. I'll give you a link to all of these free materials. And I think the key word to that is free. So please don't feel that that part of this process is a sales pitch, because all of the information I will provide to you today is available to you free of charge. So when we got started with this, we did a gap analysis for the hospital preparedness program folks here in Los Angeles County. We have 100 hospitals in Los Angeles County, and a good number of them, approximately 89 right now, are part of our hospital preparedness or healthcare preparedness program. So we have a pretty robust process here in LA County, and LA County has also adopted this as their model. But we did a gap analysis, sent out a survey to many, and what we found was more than 50% of the respondents had a lack of MCI training programs for their emergency department staff and physicians, lack of MCI training programs for the rest of the ancillary and support staff, the inability to manage a minimum of 50 patients in 15 minutes, lack of triggers for numerous operations, how and what will dictate when you would need to stand up your code triage response or your mass casualty incident response. Again, there were no clinical staff to be able to provide if, in fact, we were overwhelmed and there may only be one physician to support the response. So I'm going to show you a video. This is a time lapse. There's no sound, so don't worry. It's not your computer that's not working. I just want to show you this time lapse. This particular setup was done in 2 years ago, and we did it in just under 15 minutes. We were accomplished and set up in 14 minutes and 45 seconds. So I'm going to let the time lapse run through and have some fun. And there were a dozen of these folks, of all of the people you see out there, that had actually been trained in this prior to this event. This setup was done, again, with just-in-time training, processes, and just by having access to the equipment that needed to be rolled out. I want you to make note of the building to the right of your picture. That is our Center for Health Education. One of the benefits we have living in California is that we deal with pretty nice weather on a regular basis. But our backup plan is to utilize the Center for Health Education and utilize those classrooms to be treatment areas where needed. All of the equipment you see in front of you is on wheels and can be moved to anywhere on our location within a relatively short period of time. It may take us 20 minutes to get set up if we had to go to the back of the hospital due to building damage due to an earthquake. But the key function is to be able to utilize this Center for Health Education. This is where we use for our flu surge as well, because instead of having to set up tents and running electricity, this building already provides restrooms, running water, heat, lights, data drops, et cetera, for connectivity to your facility. So as you plan for these events in your facility, just know that this can be done internally as well as externally. Now, I was mentioning that we've done work with the clinics. Well, I've been doing some work with our local LGBT Center. They wanted to set up a mass casualty response plan at their facility, and they adopted this plan. And I'm going to let this time lapse play for you as well. These folks were done in just about 9 minutes. Really impressive. And this was the first drill that they had done after our initial test drill, probably about 6 months prior. And you can see as to how it was modified for their purposes and how all hands are on deck to be able to receive this process. It was really pretty amazing to watch this process take place in the clinic setting to see how this was truly scalable for any size, any modality facility. So what is the benefit of using this 15 till 50 plan? Well, in the clinic setting, especially with CMS mandates for the federally qualified health centers to be part of a community-based response, they have taken this on to be in a place of preparedness. All healthcare facilities must work together to do their part to serve the whole community as part of our whole community plan. This is key because these folks are going to be receiving victims from their local community, as you know, from folks right outside their door. Now, you deal with EMTALA issues, and you know, it's like if you tried to send folks from the hospital to the clinics, you're going to be dealing with, you may have some obstacles in dealing with that. But if you're able to have folks visit the clinics first, be stabilized, be treated for minor injuries, and just send the higher acuity patients to the hospital, this streamlines the process and helps to alleviate some of the stressors within the hospital environment. And the expectation for the FQHCs is to help evaluate, treat these folks, and get them to a higher level of care where possible. And again, this is a critical component to our community response. So with the initiation activities, we'll get into, so whatever the event may be that occurs, you know, folks across the country are dealing with different natural disasters, whether they're tornadoes, hurricanes, flooding. Although that you have a little more time with floods to respond, we deal with earthquakes here where we don't get any notice, not minutes, not seconds. It just starts shaking and we are now ready to roll. So that event takes place. What would happen in our emergency department or in the hospitals that I work with is that we would be notified via MAC or ReadyNet. Now here in Los Angeles, MAC is the Medical Alert Center. I know elsewhere in the country, MAC is the Multi-Agency Coordination Center. Basically serves the same purpose, same function. We just have to be special here and have our own names for things. Then whoever it is, our radio nurse, our MICN, our mobile intensive care nurse that receives these radio calls would notify the house supervisor, who would then initiate a code triage alert. Our house supervisor is usually our admin in charge during the course of evenings and during the day. We would also notify our chief executives as well. To alert all, the whole house staff, we would notify via overhead page of a code triage. The charge nurse, nurse manager, and the ED would then assign staff for a response. They'll distribute these treatment area assignment boxes, of which I'll show you in a minute. And then all staff are to establish the external treatment areas I demonstrated to you earlier. And then we already have our minor treatment area segregated from our higher acuity patients, and they would already be heading towards the Center for Health Education, as I had directed your attention to earlier. As part of that initiation, putting on your PPEs as appropriate, depending on what the event is. Charge nurse is going to clear out any existing patients to receive new ones if we're, especially the folks that are in our fast track or just after the sniffles or minor issues. Turn on your handheld radios to conduct radio checks, and then we would update MAC as the incident and the incident commander as new information is received. We notify MAC of our the service level of our facilities in a red, yellow, green, and red being in distress. Yellow, the facility is in distress, not the folks that are working within it. Yellow would be a moderate impact, and green would be open to any and all. And that's so we can divert some of the patient traffic to the facilities that may still be functional, as opposed to sending them to folks that may have some type of incapacitation. Within the clinics, now this, you would receive that they had been in an MCI. Many of our clinics are FQHCs, a part of a organization and association here in Los Angeles County that are on ReadyNet as well. So this is how notification would be sent out. But on a worst case scenario, people just start showing up to your door without any warning. So you have to start to be somewhat savvy and understand that this could potentially be a trigger to elevate this up to your executive team or whoever has the authority to initiate this plan. Because you have to remember, if you're going to initiate this plan, it's not going to be business as usual. There'll be an impact on your facility, whether it be fiduciary and or an impact on your clinical staff as to how ratios may go out of balance, et cetera, et cetera. So to have an executive order, so to speak, to implement this is crucial. We established a triage area to manage a sudden surge. Again, expect 20 to 50% increase in patient volume. These protocols are a way of keeping control of the situation and the allocation of resources. We switch from a patient-based care to population-based care, and basically what that means is just to do the most good with what we have available. And hopefully your preparation process puts you in a place to have a whole lot more available than you may have before you started planning. So with your initial activities, the roles are assigned, the patients are processed for discharge or admission. Our case managers would ascertain the discharges. They would consolidate, we would consolidate remaining patients, perhaps the cohort, similar issues, so that we can open up patient beds. Count of available bed leads to the disaster lead, and we secure our whole facility. We lock down the whole area, and there's only one path of entry into the facility, and that is through our mass casualty triage area. And I say that because even our ambulance traffic, even if it was Mrs. Smith that was living down the street, has a history of cardiac issues, if she is going to be treated on the day that we are responding or at the time we're responding to a disaster, she will be triaged and treated through that process as well. We would have to shift everything. If you did not, you would never have control of this process. And if you don't lock down your facility and secure your areas, you will you start to have breaches in your protocol. So with setup, what does this look like? As I mentioned, there were go boxes. Well, those are what you see up in the upper left-hand corner. And please do not be dismayed by seeing that there's blood cultures on the shelf. I think there's a pair of goggles up there. There's bags on top of the boxes. This is what that room looks like on a regular basis. This is the radio room where we receive calls from the community, from our EMS providers, as well as our ReadyNet system. So these are where the go boxes are. It's a central location within the emergency department where the charge nurse would get these boxes and delegate the treatment area leads, whether they be the delayed treatment, minor treatment, triage, and or immediate. Our morgue gets set up as a component of this, but it's not necessarily the initial setup plan as we get things rolling. To the right picture, you'll notice a yellow linen bin. That is what we keep our cots and easy-ups in, as well as the tarp that's sitting over the top. Everything is color coordinated. There's a red bin that looks just like that. There's a green bin for our immediate, delayed, and minor treatment areas. There's also a black bin that we would set up our morgue or expectant treatment area. And there's also a supply trailer in there that we're able to retrieve some supplies from to help us with our setup. This is the LGBT Center where they have their supplies in the parking structure, in the ground floor of this parking structure, and you can see how well they have things organized and ready for rapid deployment. There are gasoline generators, there are fans to move around some cool air. They've also purchased a few swamp coolers to help keep things cool even on the outside by moving that cooler air with these large fans. This is another hospital that has adopted it, and again, unaffiliated, but I just wanted to demonstrate the way the different layouts take place at the facilities, because each facility is designed in a different capacity. So to identify the location that would best suit you for ambulance traffic, ambulatory traffic, it would have to be something that could be done through a site evaluation on your behalf. But you can see that the equipment is the same. Cots, tarps, they don't use color-coded carts, but the carts it keeps everything mobile and rapidly deployable. We would set up, as I told you, we lock down the facility. On the right-hand picture, you'll notice a driveway. That's our normal ambulance entrance for our emergency department. We have, you can't see in this picture, there are K-rails that get moved into place to keep ambulance from pulling into that location, so that all ambulance traffic will then roll down to where you see in the picture on the left, which is the opening to our loading dock, which is where we set up our external treatment area. Loading dock has a gate on it that we can close down to any opening that we need to, and we can keep it a little bit more secure. So this is what the treatment areas look like once they are established. Just a little back story on this. The three nurses in the red vests, we were having a conversation during one of their meetings as to how we set these supplies up, and they were in disbelief that this could be set up in 15 minutes. So we had a little Saturday morning test set up with these three nurses, the gal in the back in the gold vest, and myself, to see and to demonstrate how readily and rapidly we could deploy this equipment. And this particular setup day, both treatment areas that you see right there, we had them set up in just about 9 minutes with just the 5 of us. So this is possible, this can be done, and I tell you true, even when 3 of them had never been trained, just through just-in-time training, we were able to move all of the equipment into place and be prepared. You'll notice to the right of the picture on the left, I hope that wasn't too confusing, in the delayed treatment area, the equipment that's on the right-hand side, and then in the immediate treatment area, the equipment's on the left. Well, those are the same equipment carts. That equipment can be plucked from those carts from either side of that location, so that everything that's out there, one cart would serve 2 areas where need be. I also want to make note of those color-coded bins, the laundry bins, because any belongings that we would have to take from patients, especially if this was a criminal investigation, we would need to have some evidence collection and some protocol. So by having somebody triage to the delayed area, their personal belongings will go into the yellow cart, or in the back of the immediate area picture, you'll notice a red cart in the back there. That again was for that same purpose. This is a minor treatment area set up at another facility. As I had mentioned, in my facilities, we use this on an internal level because of rapid discharge for these folks out the back door without getting them involved with the higher acuity event. But you can see the process is the same. It's just a matter of how and where you choose to set your supplies up. So what does it look like when it's complete? Well, we used to use gurneys to try to set up for all of these casualties, but there wasn't enough gurneys in place. So we decided to purchase cots. So now we have the treatment areas established with cots, and the gurneys and wheelchairs are just used for transport of these patients. So these folks will be set up in the cots. We would transfer them to a gurney to move them through the rest of the house. Signs are posted, the supply carts are out. While we're waiting for patients, IV lines start getting set up, O2 tanks, whatever PPE is needed, and then the treatment areas are ready, and complete that with a radio check. Also included in the resources that you'll have access to are layout maps as to how to set up your treatment areas. The one on the left, again, was that parking lot you saw with the LGBT Center. And on the right is the layout map of what it looks like at the hospital's loading dock. So with that, before we get into roles, I think I'd like to open this up to a few questions if possible. So if you have any questions that you up to this point, by all means, please feel free to ask.
I'm going to relaunch that first poll as well, since we hadn't prepped that. But basically, we're interested in knowing, have you ever worked a mass casualty incident? And have you ever implemented the 15 till 50 at your facility? We do have a couple comments. I'll go over them here. One question here from Kim is, could this plan be scaled to fit a nursing home or an assisted living center?
The answer to that question, Kim, is absolutely. With the hospitals that I've worked in, we've had long-term care facilities that were under the scope of our emergency operations plan, but we set them up with their own supplies to be able to rapidly deploy, and they can triage other patients as they came in, whether to do this just in that long-term care facility or also to be adjunct support for the hospital. So yes, absolutely. And we have implemented this in 2 long-term care facilities under my care. Thank you for the question.
Another question asks from Michael. He says he's here in New Jersey and we have a common triage tag that first responders use, but not a common cloud database for the entry of patient info, so that hospitals will have a head start on what's coming to them. Do you have experience working with a central triage tag database? And if so, what works best?
As I had mentioned earlier, nice question, Michael. That's a good one. In the hospitals, we use a ReadyNet system that is basically a database for the whole county, so that we would input patient data into that information so we could track patients from wherever they come in from our EMS providers, because we may be receiving victims from all over the county at any given time. So the database that we use is this ReadyNet system. We would use paper tracking where if we didn't have connectivity due to that earthquake until we were able to start to upload that information. But there is a neat little way that we register folks that the information goes out to our command center, who would then input that patient information into this central database. It's a very effective tool. We use that here in LA County regularly for drills to ensure knowledge of that process. So yes, it does work well. I will add a caveat that we don't use, well, I won't get into triage tags at this particular moment, but that's how we would be tracking those patients as we move along. Thank you for the question.
Another question here, Chris, is regarding MRC units, and I'll get to Rainika in a moment. But I see two people mentioning MRC, both on the Zoom webinar platform and one on safeandready.org. So I figured I'd address that. Any thoughts on how MRC units through health department can participate in this program?
Absolutely. I work extensively with the MRC, and here in California, the ESAR VIP program for disaster volunteers is just a disaster healthcare volunteer network. In implementing and utilizing the folks that would be available to us for that purpose. The MRCs would be definitely helpful with them, as well as the disaster volunteers, to assist the hospital, but it wouldn't necessarily be during this triage initial response. I don't know how you get notified in your own states, but here they would have to be requested through the county, who would then deploy these folks out to our facilities. And reality is that it could take anywhere from 24 to 48 hours before these folks would be able to come to assist us. So to utilize them in a triage type of an environment is unrealistic for us, and we cannot put our hope that that would be the case. So we had to be self-supportive, but to utilize the DHV and the Medical Reserve Corps as adjunct faculty for us when we needed the support within our facility after responding to the initial event. Great question, though. And really, this it's a neat way to get this stuff involved. I tell you, with a brief conversation I had yesterday with Tom, is that, utilizing our CERT folks, DHV folks, if you're in your community, to assist in your communities in triaging some of these folks, so we can then transport folks that are higher level of acuity from these communities to the hospital. So your help is definitely appreciated and, valuable. It's just a matter of which way that's best served. But thank you for those questions. That's great.
Chris, another question on the board here from Rainika. What are some of the biggest barriers an organization has to overcome to get to the point of being efficient?
Probably the biggest barrier is our facility leadership. It does take a little bit of work for training, and if you don't receive dollars to put on the front end to at least provide training to your staff as to this process, or at least a good number, a handful of them that would have to respond and how you implement this. But once they see the value of being able to be set up and put something like this into play, actually just by having a designed process has been one of the biggest leverage pieces for folks that I know that have brought this into their facilities, to demonstrate that this is there, this works. It puts you in a place of preparedness, and this works with active shooter, with earthquake. If this was a natural disaster or a human-induced one, that your facility needs to be prepared. So I think the biggest barrier, one, is your leadership. Once they're on board with this, I think you'll find that this is works out to be pretty seamless. One of the other obstacles we had at first, although I came from the emergency department, the facilities that were implementing this around the county, not everybody came from a clinical environment. And being able to sell this into the ED, to have them have a plan, I tell you, once the emergency department realized that this plan worked and functional, I have no greater support than now all of the emergency department personnel. So great question, and I hope that was helpful in answering that question.
I've got more for you, Chris. Keep me on your toes here.
Sure.
So Pamela left a comment before we got started saying that she, in her position at a 49-bed acute care hospital, she is the trauma coordinator and emergency preparedness coordinator, and they're in the process of writing protocol for surge. Now, she says she didn't believe this was a policy procedure class per se, but she's hoping that some of the materials you have can help with just that policy procedure. Can you talk to some of the guidance materials that you have that can support policies and procedures?
Absolutely. As I had mentioned earlier, being a department of one, there was nothing that I found to be more arduous than having to work off of a checklist to put plans into place. So one of the components to these free resources is a mass casualty incident plan template. That plan template is pretty much written. All you need to do is find and replace your hospital's name, your processes, your call numbers, your communications plans into this, and you'll have a written plan. Now, I'm saying this with a little caveat. A written plan does not constitute having a plan. Unless you test that plan does not work. A paper plan is great to have on tap for to demonstrate to others, and it's great guidance when you do your education, but make sure that your plan is functional. Also with that is a mass casualty incident planning guide that gives you more in-depth information as to tools you can implement into that written plan. As a matter of fact, in the plan template, there are page citations to the guide that if you had questions, you could go to the guide to fill out those that particular section in the plan with relative ease. I think you'll find it very beneficial once you tap into that resource.
Just a note about that, under the resources section, when you're logged in on safeandready.org to this particular training, you'll see the template and the guide right there for you. So in addition to that, there's the link to the media kit, which is posted on the California Department of Public Health website. So all those resources are pretty handy for you. Also want to point out something that Megan states here. She says hospitals are considered soft targets. So she's concerned that when people hear about the challenges for setting up kind of this mass casualty incident triage area and this whole operation, it sounds like she's concerned that the bad guys could target the triage area. So any thoughts on securing the medical triage area and, any best practices around that?
Sure. As I mentioned, the reason why we use the loading dock is because there is a large metal gate. It's not just a wire mesh gate, but a gate that will close all the way if we needed to. Doors can be secured. We lock down our facility, monitor paths of egress just to ensure that the facility stays locked down. And the purpose behind that is specifically to address Megan's concern as well, that we potentially could be at risk for something like that. So if we don't control and protect the environment that we're working within, we would put ourselves at risk. So to be somewhat preemptive and to anticipate things like that, being able to use a locked up facility or a facility, an area that we can lock down and secure is crucial. One of the other key components is that we work very closely with the city of Torrance and their police department. So if we had to call a code triage or a mass casualty response, they send 6 officers to our facility, actually 5 officers and a sergeant, to assist us with crowd control, traffic control. So this is part of your community-based planning. You need to bring these folks in to assist and how you can support one another in a process like this. Great question. Tom, I think we should start moving through a few more of these slides and
Sure
maybe the rest of them for after we're done.
You got it.
Okay. So thank you for the great questions, folks. I tell you, we've worked through quite a few of these events, and we've tried to address the process when they would come about. And these were things that do happen as part of your drills and training, that you will identify gaps, and that is the purpose of doing these drills. How do you protect yourself? How do you protect your patients? How do you protect your facility? So great questions. Nice response there too. So now in terms of roles, our command center gets set up within the first 15 minutes as well. The expectation that my hospital leaders will be staffing the command center immediately upon notification. They will come on out, they'll coordinate all of the equipment, personnel, labor pool, ancillary services, and the patient flow throughput into the facility. One of the biggest things with my emergency department, they keep asking, well, how many beds do we have available in the hospital? Well, quite honestly, that's really none of their concern. Their concern should be to notify the command center and let the command center do the work for them. So, and that is the purpose of bringing everybody together at once and within 15 minutes. This is a tool we use in the command center. It's called Hicks in a Box, and basically it's color-coded for all of the Hicks positions, or at least the sections. You have your command section, planning, logistics, ops, finance. In the back of the forms box is the incident response guides that will walk you through pretty much any event to help guide your leadership through their Hicks process. The vests are color-coded to go along with that, so if you're wearing a blue vest and you have a yellow binder, something is off. And again, you learn things through training that even having the best laid plans, having everything color-coded, it turned out that the individual I used to work for was colorblind, so I had to make sure that font was a little larger and legible for that purpose. The treatment areas, again, it's emergency department centric, so you have a disaster lead, a charge nurse that stays inside, as well as a disaster lead outside. You're set up in decon folks. These are facility and clinical staff. You have your support staff such as EMTs or whatever you use in your facilities. Triage is nurse. Your minor treatment areas, if we could have 2 nurses, a doctor, registrar, and respiratory therapist, these are all crucial, and you can see that that is the objective for the other treatment areas as well. Now, can this function with 1 doctor in the immediate and delayed area? Absolutely. Can it happen with less than 4 nurses? It would be a challenge, but it can be done. Same thing with the minor treatment area. Again, that's segregated, so we need the extra support in that location. Within the clinic, your facilities and clinic staff work together to set things up. Once the area is functional, the facility team will step back, let the clinical folks take over the treatment. Facilities will continue to support. You're going to identify who's in charge on the clinical side, who's going to be given direction, know where the medical supplies are located, how to access them, and follow directions. Again, I mentioned the ReadyNet communications. We use telephones, but our telephones are on a VoIP system. So if servers go down, we also have backup landlines. And that is our emergency phone system throughout the hospital. Everybody has access to within the hospital, has access to the extensions for that purpose. If you have fax machines in your facility, you have access to landlines in your facility. So keep that in mind as part of your planning. The handheld radios, you can use cell phones where necessary. There are some pretty secure apps like WhatsApp or Zello that you can communicate with your teams. And of course, ham radios. The ham radio operators that we had at the facility were really incredible in helping us to establish that process. As a matter of fact, they provided training. So at the 2 hospitals I worked, we had at least 20 ham radio operators at each site that were hospital personnel that also could operate ham radios, as well as bringing in the volunteers from the community, the ham radio volunteers, to help support that too. Pharmacy and radiology also have a designated role. The pharmacy has pre-stocked med carts that they deploy to both the immediate delayed area as well as the minor treatment area with a pharmacy tech or a pharmacist to be able to dispense those meds from paper if need be, but also to work through that process. Radiology deploys mobile equipment. There's a C-arm and portable x-ray machines. We use PACS carts. PACS is basically a web-based system that we can read x-rays on site, although now we're moving into digital portable x-ray machines that we can actually see films in real time. But those are deployed immediately upon notification. Case managers, as I had alluded to earlier, will increase our surge capacity to accommodate the influx of patients. They coordinate the discharge, they establish the patient discharge area, they coordinate activities to expedite discharge, including the transportation of those individuals, and assist with the Family Information Center. They would also assist with side start assessments, and that's basically a psychological triage process to evaluate individuals where need be. And we would, chances are, use some of our social workers to assist us in that capacity. Public safety, as I had mentioned, we'd lock down a facility, access control, crowd control, traffic control, and then they liaise with our local police department, and we train with our local police department frequently. Facilities, plant operations. This was an untapped resource that I had when I was working on the clinical side and didn't realize what I was missing. My position was shifted from under the emergency department to the facilities folks, and I found that there was a host of resources and folks that were very eager to assist. So they're going to go through the immediate structural evaluation, especially since we deal with earthquakes here. A true check takes about 1.5 hours to 2 hours, which was worlds beyond the 10 minutes we used to simulate at the beginning of these drills. They'll report the findings to the command center. One of the other resources was the construction folks we had on site, because we're constantly in states of construction here in California with seismic upgrades, et cetera. And we have these construction folks walking around our hospital with structural integrity points and blueprints to our facilities. So we might as well put them to good use. Facilities can assist with decon, assist with infection control if we have to set up little isolation areas, assist with patient transport. They definitely work well as runners, and they need to make sure that our utilities are viable. You can see triage. We can use different types of materials to do so. There's a triage nurse, my treatment area lead, and an EMT carrying a patient to a location. Right behind them, you'll notice that there is a decon trailer. That trailer gets set up for every single drill we do, whether it's needed or not. And the purpose is that becomes part of the muscle memory, so that if we needed this, it's already in place and set up, and we could go through the decon process, or if not, we just bypass, as you see what they're doing right here. Treatment areas, you can see folks being taken care of. We use local nursing school students for victims. Works out advantageously for both of us. One, if they're going to come to work with us after they're done with school, they already start to know our process. And two, they get to see what life is like on the other side of the fence as a patient, as opposed to just a caregiver. Don't forget about your functional and access needs. Plan for pediatrics. This young lady is a member of one of our local middle schools that I partnered with to provide us with middle school students to participate in our drills to enhance our pediatric capabilities. This is a leadership program. They need to do community volunteer hours, and they get a good 4 to 6 hours working with our facility during these exercises. Supply chain, tracking supplies. How do we manage through this? Well, you saw those supply carts out in the treatment area. Well, there's exact replicas of these staged at the warehouse, which is about 200 yards up the street from the hospital. So that if we depleted the stock on those carts, we would give our warehouse folks a call. They bring down their truck, they pick up the old carts and drop off the new ones to us, and then they would restock those carts down at the warehouse where we keep these supplies and be able to get this to us where need be. It's a great system. It really works well. But again, it's a matter of training to this process. So let's get into the nuts and bolts of this toolkit, and hopefully you'll find this to be a good thing. This truly is a comprehensive suite of resources. You're going to find just about anything you need. I mentioned the incident planning guide, or the incident guide for healthcare entities. There's also a plan template that I'll cover here in a second. There are videos in here. There are PowerPoint presentations in here. There's training materials in here. There's equipment supply lists included in this. There's an incident action plan that's already filled out for you for mass casualty events. I think you'll find that pretty much soup to nuts is available to you in this toolkit. All right. And chances are you have these supplies on hand, or many of them already, whether they be vests or other assorted medical supplies. This is truly an exercise in logistics, and how you stage, where you stage, and how you respond are going to be crucial as to how you go about. So the plan template, as I had mentioned to you before, comes with instructions and everything. It's really an easy to populate document. if you put this into your facility, you download this plan template, you will have, well, depending on what time it is, it's 11 o'clock where I'm sitting in the morning. So by the end of the day, you should be able to have a mass casualty plan in place that will no longer be template, but your mass casualty incident plan. As a matter of fact, I use this template to fill out my hospital's plan just to make sure that this was that functional, and I think you'll find it very accessible. So you'll already have an example on that site as well. Your planning guide gives you a little bit more comprehensive explanation of the 15 till 50 model, walks through step by step in developing the program in your facility. These two items are also available on the Joint Commission Leading Practice Library, so I think you'll find this to be beneficial to you as well. I mentioned roles, and you'll notice on this particular slide that we have the behavioral health, blood bank, case managers, central supply. All of this has what their roles would be, and this goes from our behavioral supplies down to, I don't know of anybody with a Z, but how about to radiology or transportation. So you'll find that there are tools and roles for each staff of your facility. Told you about the videos, there's photos, there's audio relating to this process. There's actually, well, you'll find a host of recorded materials there for your access. In the Toolkit Library, you'll also find that there's a train-the-trainer PowerPoint presentation, a healthcare responder PowerPoint presentation, other assorted presentation materials, patient care forms, job action sheets, sample plans, your executive briefing materials, where how you can create some buy-in, and of course maps to assist you in this process. Now, where you can find this toolkit is located on the California Department of Public Health website, and I think you can see the link at cdphready.org, and there's a whole host of information there. This happens to be the 15 till 50 mass casualty incident toolkit, but I encourage you to go and look into this. Even if you don't use this in toto, you can at least adopt and adapt any of the resources you find available to you. Again, going through part of this process, you'll see there's another minor treatment layout area map. This is a trainer PowerPoint presentation, and of course your plan template. Now I'm just going to let this one run one more time. This time this time lapse is annotated, so maybe it'll make a little bit more sense. Now, one of the other things I would like to add that I didn't mention earlier is that all of our staff are in colored vests to their modality. So you have the red vests are our RNs. For the most part, our blue vests, although this registrar is in a blue vest, this is before we got them gray ones. Our EMTs are in blue vests, and our doctors are in gold vests. And regardless of the treatment area they're working in. So if you needed a nurse, you can identify a nurse without having to look at the back of their vest. Same thing with a doctor. If you needed a doctor, you can identify them with relative ease. So just to go over, we went through our initiation activities as to what that looks like and how to go about that, what these setup procedures actually look like, how to identify roles and responsibilities and train to it. And you can do this from department to department, as well as the 15 till 50 toolkit. One of the things I neglected to mention to you is that when the emergency department staff move outside to do this mass casualty triage and treatment, our floor staff, we send down 2 nurses from each unit in the hospital, one to backfill the ED to manage patients in the emergency department, and the other to transport admissions up to their units. The ones that come down that will staff the ED, we set up the emergency department into a mini ICU, a mini tele unit, so that the nurses that come down to work in the ER will still do the work that they do on a daily basis on their unit, just in a different venue. So we set them up for success and not trying to push them into something that they wouldn't normally do or may be uncomfortable in doing, in dealing with the traumatic aspect of dealing with a mass casualty event. So I guess we could open this up for questions and see if there are any more. I know we're running a little longer. I think we answered a few more questions midway through, but happy to open this up for a little while and see what we can do.
Sure. So Chris, one thing that I found interesting in the first poll that we sent out was that 12 people on the line have worked a mass casualty incident. When I think of a mass casualty incident, I think of a, boy, I hope this never happens to me type of thing, or, you know, this is maybe an active shooter, you know, mass shooting or a bomb explosion or something major that just overwhelms or has the potential to overwhelm a hospital. Do you think, do you see a lot of these? I mean, are a lot of mass casualty incidents happening?
Well, you know, we're seeing a little bit larger number, and I don't know if that's media attention to these things now, but there are quite a few shootings that have taken place around the country. I think it's been daily from what I've seen. But this doesn't necessarily have to be something that is nefarious. What happens if you have a bus crash outside of your facility where you have 40 patients or 35 individuals sitting on that bus that are now injured and coming to your facility because you are the closest? What happens, you know, we have an airport here. We've had a plane crash into one of the office buildings, the medical office buildings that were truly impacted. And there were a whole lot of, we had over 100 injuries from that event. That were distributed through the county, but these are mass casualty events that we don't necessarily look at in that capacity because we're looking for the big events. But these are things that can happen at any time. I mean, I'm surrounded by freeway systems. Bad things happen, and really, one bus accident can be potentially be a really bad thing. We've been able to skirt some really bad ones where a tanker truck full of ammonia overturned and they were able to staunch that leak. But if that stuff would have gotten airborne and really started to affect the downwind community, I mean, you're looking at 1,000 people plus. So, you know, it's not so much waiting for the gloom and doom, but being prepared to receive something when you're already packed. How would you manage an event of that nature? That answer your question, Tom?
Yeah, absolutely. So another question here, you know, people ask, is this just a California thing? The outside triage area. What about bad weather areas? You're from the East Coast originally.
I am. And quite honestly, you know, we do get bad weather here too, believe it or not, other than what you see during the Rose Bowl or otherwise. We have again, we move our stuff internally. We would utilize our Center for Health Education. So we would have an internal area for that purpose. We would still triage them in basically the same place because there's a walkway that gets us into that internal location. But again, in any environment, this doesn't have to necessarily be just something for California that's set up outside. But if you can identify locations within your facility that you can utilize, like maybe it's a waiting area in one of your outpatient sections of your hospital, or someplace else that you would be able to set this stuff up. You don't necessarily need canopies at that point. Where would you be able to do this? And that would be part of your site evaluation as to how this could be implemented. I tell you, I have folks here in California that do not set up outside and just do this inside this huge emergency department waiting area that they have. And that's in a pediatric specific facility, so that they don't have to set things up outside, other than if it was a decon event, of course, we'd have to modify. But yeah, this can be done internally just as well as it can be done externally. Everything is mobile, portable, and rapidly deployable.
So one of our attendees sent us a private message, just to panelists, that says, "Thank you both so much. Tom, you provide great classes." Of course, everyone probably thinks I'm lying right now, but I swear this is what she's put. She also says, "Chris, I hope to have your knowledge base in my little brain at some point. Great job today." So that brings me to the next item here. Chris has graciously offered to attendees to have a telephone consultation if this program looks like it could be usable or adaptable in your environment. Take advantage. So I just launched a poll. Would you like a telephone consultation with Chris to talk about implementing this 15 till 50 plan? And certainly a lot of you may be good with just the toolkit, or maybe it doesn't fit exactly. Maybe you're not working in that environment, but it is something that Chris has offered. So the other item in the poll is, was this information useful and informative? So obviously we always want to have useful and informative presentations hosted here. So please let us know. Your feedback means a lot to us. Chris, any closing comments to our audience here?
Well, one, I would love to know if you are implementing this in your facility. I'm not looking for any residual checks or anything like that. That has nothing to do with this. But I just had a curiosity to see how things work and how you've been able to implement. As Tom had mentioned, I am available for a phone call at pretty much any time to help you down that path. And of course, the phone call is free of charge. And then if you would like assistance in implementing these in your facility, perhaps you'd like me on site to come out and train, we can do that, and we could work out details to that at some point. But by all means, the information that was provided to you and the resources are free. So please utilize what you have available. And if I could be of further assistance, I am happy to provide any guidance, assistance, brainstorming with you to assist you down that path. We've implemented this in trauma centers, pediatric facilities, long-term care clinics. So this has been modified by many different individuals, individual facilities that may be unaffiliated. And I'm happy to share any of that knowledge with you when and if you find that advantageous to you. So thank you.